All right, let's get right into it. Today, we're tackling one of the most critical, time-sensitive decisions you can make in the ICU, picking the right vasopressor. We're going to build a really clear, simple mental model to help you bring some order to the chaos when your patient is crashing.
So, picture this. You're at the bedside, the alarms are screaming, and the blood pressure on the monitor is just tanking. This isn't just some textbook question. This is a real crisis, happening right now. The choice you make in the next couple of minutes could literally change everything. So, where do you even start?
You start with a system. Instead of just grabbing a drug and hoping for the best, you use a framework. We're going to walk through that exact framework today. We'll start with the basic questions, then break down the key factors guiding your choice, put it all together in a quick decision map, and finally, cover the ultimate safety net for when you're not sure.
So before we even think about reaching for a syringe, we have to ask the most important question of all: why? Why is the blood pressure low in the first place? The foundation of any good decision here is a quick, systematic breakdown of the problem into 4 core factors.
Okay, let's jump into our first and honestly our most important factor: the mechanism of shock. This is the root cause. Are we dealing with a problem with the pipes, the pump, or the amount of fluid in the tank? Getting this one right sets the entire direction for everything we do next. First up, we have vasodilatory shock. You see this all the time in things like sepsis or anaphylaxis. The easiest way to think about it is like this. The body's plumbing system, the blood vessels, are just too wide and floppy. The pressure drops because the pipes are too big. We call this low SVR, or systemic vascular resistance. So what's the fix? Well, we need something to squeeze those pipes tighter.
And that leads us straight to our drug choice. For that wide pipe problem, noradrenaline is almost always your first choice. It's a fantastic vasoconstrictor. But, and this is a huge but, look at that special case, anaphylaxis. Here, adrenaline isn't just an option, it is absolutely mandatory. Why? Because it doesn't just squeeze the pipes, it also opens up the airways, which is obviously critical in a severe allergic reaction.
Okay, now let's completely switch gears. What if the pipes are fine, but the pump, the heart itself, is what's failing? That's cardiogenic shock. The heart just isn't strong enough to push blood forward, so your cardiac output is low. The goal here isn't to squeeze the pipes, it's to make the pump work better. We need an inotrope.
So what do we grab? Well, this is where things get a bit more nuanced. It really depends on the patient's blood pressure. If they still have a decent pressure, say above 80 or 90, dobutamine is a great choice to just boost the heart's contractility. But if they're profoundly hypotensive, you need adrenaline because it gives you both pump support and that squeeze you need. And then there's the special case of right heart failure, where milrinone is often preferred because it helps the pulmonary arteries.
And our third big mechanism is hypovolemic shock. This one's pretty simple. The tank is empty. You see this in major trauma or severe dehydration. The pump is fine, the pipes are fine, but there's just not enough fluid in the system. The first, second, and third treatment is always to refill that tank with fluids or blood, period.
And I have to be really clear about this. This is a huge critical warning. Using vasopressors here is like squeezing an empty tube of toothpaste. You're not going to get much out and you're just going to damage the tube. Pressors are only a temporary bridge to keep the brain and heart alive while you are frantically pouring fluids in. Using them long-term without filling the tank will absolutely destroy organs.
Okay, so once we have a good idea of what kind of shock we're dealing with, we can get a bit more advanced. This is where we use monitoring to really fine-tune our choice. Factor 2 is all about looking at the hard data, the hemodynamics, to confirm what we're thinking and dial in our therapy.
Looking at the SVR is a game changer. If it's low, the patient is often warm with bounding pulses. That screams wide pipes. The answer is norepinephrine. But what if the opposite is true? The patient is cold, mottled, and their SVR is sky high. Their body is already clamping down as hard as it can. Adding more vasoconstrictors here is dangerous. Instead, we need to support the heart and maybe even open up the vessels a bit with something like dobutamine or milrinone.
Cardiac output tells a similar story, but with a fascinating twist. Low cardiac output? That's easy. It points straight to pump failure, so you need an inotrope. But, and here's the paradox, what if the cardiac output is high and the patient is still hypotensive? This is classic early sepsis. The heart is working overtime, but the pipes are so wide open that all the pressure is just lost. So a high output doesn't mean everything's fine. In this case, it tells you that you need a pure vasoconstrictor like noradrenaline.
All right, now let's zoom in even closer on the heart itself.
Factors 3 and 4 are all about its specific condition. We need to know how fast it's beating, and we need to check on that often neglected right side of the heart. These little details can totally change which drug we choose.
Think about it. A heart that's already racing at 140 beats per minute is a stressed out heart. It's burning through oxygen like crazy. The absolute last thing you want to do is give it a drug that kicks the rate up even higher, like adrenaline or dopamine. So in tachycardia, you reach for agents that don't mess with the heart rate as much, like noradrenaline or vasopressin. On the flip side, if the heart is going too slow, we can actually use that heart rate boosting side effect of adrenaline to our advantage.
And this brings us to a really expert-level consideration, the right ventricle. If the RV is failing, or if there's super high pressure in the lungs, you have to be so careful. Squeezing the blood vessels in the lungs can make things catastrophically worse. And this is where drugs like milrinone and dobutamine are just beautiful, because they actually help relax the pulmonary arteries, which takes a huge load off that struggling right heart.
Okay, so we've looked at the mechanism, the numbers, the heart rate, and the RV. How does this all come together when you're standing at the bedside and the pressure is dropping? Let's put it all into a simple, practical decision map. This chart is basically our whole framework in a nutshell. Look at septic shock, classic wide pipe problem. So, norepinephrine is your first choice. Now compare that to the two types of cardiogenic shock. If the patient is super unstable, you have to prioritize blood pressure first with norepinephrine to perfuse the heart. But if they're a bit more stable, you can go straight for pump support with dobutamine. See how every single choice here flows logically from that four-factor analysis?
But let's be real. What about those chaotic moments where you don't have all the data? You don't have the echo, you don't have the advanced numbers, but you have to act right now. Well, there's a rule for that.
And here it is. This might be the single most important rule of thumb we've talked about. When in doubt, start norepinephrine. With the one single exception of anaphylaxis, it is almost always the safest and most reliable first move you can make. It buys you time to figure out what's really going on.
So why is that? Why noradrenaline? It's because it gives you reliable vasoconstriction to maintain blood flow to the two organs that cannot fail, the brain and the heart, but it does it without causing the dangerous arrhythmias or the crazy high heart rates you can get with other drugs. It's effective and it's relatively safe.
So we'll leave you with this final question. Starting the right drug is only half the battle. You've done it, you've stabilized the patient, you've pulled them back from the brink. But now, the real art of intensive care begins. The next and most critical question is always, what's your plan to get them off?